I'm wondering if
I just think that's
osteogenic information and experience you've been looking at, because I know we haven't had a chance to talk about that before, and I know people are probably going to be interested in that orthodontic approach. Would you like to delve into that now?
Sure. I don't have data on this yet.
I think
not
a lot
good
of,
data. I have.
I'm sorry. I think a lot of people may not actually know what we're talking about. So maybe you should start and actually describe those procedures and what your expectation is from that procedure.
Okay. Well, let me go to the easiest form. The easiest form is on the lower, usually on the mandible, on the lingual or the inside. People have bumps or tori. They're just exostoses. They're just bumps of bone. This is where we did it, and I did it with Tom Wilco, and he was the inventor of the Wilcodonics. And Tom took off the lingual tori, and what it did, and some of them are quite big. I mean, they're the size of a grape. They're that big.
Sure.
He took all those off. Now, me getting really data that you would expect as a physician, and what I'm going to tell you, I don't have PSGs before and after. What I have is pulse oximetry before and after. I am amazed by removing the tori how much the heart rate changes and how much apnea goes away. We've had as much as a 50% reduction of AHI, at least through pulse oximetry AHI, and we do use the Minolta 300i, which is a high-resolution pulse oximeter with patient safety software, which is an algorithm that manages the data, because the 300i will put out 0.1% of oxygen, so it creates a graph or a curve that you can apply an algorithm to it. So it's way more accurate than most oximetry that's on the market. I don't know anything that's even close to it on the market as far as, yes.
When you describe the removal of the tori, are you talking about a simple theory of there's now more space in the airway, or is there another theory that explains why sleep apnea would get better?
That's all. I think all it is, Barry, is you made room for that tongue and it took advantage of it.
Okay, so the tongue now has an opportunity to be in better position.
Yes, and some of these were huge that we took out, and we got remarkable numbers. The patient stopped snoring. A lot of times they felt better. They woke up more rested in the morning, just like you put an oral appliance in or something. And it was pretty remarkable. And so that was the first thing we did. And now this is all of my ideas. And like I said, I wish I had more validation. The one that I have validated to a degree is, again, the vertical dimension. If you look at most people that have sleep apnea, they have fairly worn teeth and they've been eroded by the GERD and whatever. Well, when you go back to my nathology background, what I learned to do was full mouth reconstruction. In other words, I do a crown on every tooth and some people are really damaged. And when I do that, I change the oral cavity volume. So the crowns, I go in and I use my pulse oximeter and I set the vertical dimension based on my pulse oximeter and the lateral ceph the same way as I do for the oral appliance. And we've been able to do fairly remarkable things just by changing the vertical in between the teeth to a more predictable position. And what you'll find is like you said, some people are better with less vertical and some people are much better with more vertical. But it's the only way you can tell that is we make plastic teeth that they wear, and then we run the pulse oximeter at night and see what happened. We do 3 nights. And that's how I set the vertical. So the vertical matters. I can show that. Now, traditional orthodontics can only move teeth within the available bone. It's almost like the bone is a foundation and the teeth are within a foundation. And if you move the teeth outside of the foundation, you move them outside of bone and you get you get damage from the orthodontics itself, especially in an adult. Like, to consider treating you or me, and you're not going to grow bone at your and my age. But with the by using the what's called the PAOO, the periodontally assisted osteogenic orthodontics, what it does is you take, this sounds gross, but it really works. You take the gum tissue back away from the teeth, and you actually take away all the cortical bone and put the gum tissue back. You add some bone back in there, but you put it back, and you've set up an extreme inflammation in both the maxilla and the mandible. Now, for the next 6 months, you have an 8-year-old again, and you can increase the width in the posterior dramatically because of this. You can move the anterior teeth forward and take the bone with it. So you get about 2 to 3 times the amount of movement with this type of orthodontics that you get with traditional orthodontics. And the University of Washington was compared against the PAOO, and it showed that the outcomes were actually more stable when you did it with the osteogenic orthodontics than they were with traditional orthodontics. Mm-hmm. And this Wilcodontic procedure has been done for the last 20 years, but it was always done for cosmetics. It was never done for airway. Mm-hmm. So there's no airway data on it. There's tons of data on it that it doesn't cause problems, and the outcomes are predictable, but they've always marketed it as fast orthodontics. In other words, if you and I wanted to get our teeth straightened in a hurry, that was how to do it. But what we're finding is by moving the jaw apart this way, you gain more oral cavity volume. The other thing that we do is if there are tori there, of course they're removed. Mm-hmm. And on the palate, you can take away some excessive bone on the palate. So what you've done is not only move the teeth to make the oral cavity volume bigger, you've increased the oral cavity by taking away some excessive bone that occurred there for whatever reason. And these people are doing remarkably well.
So this has some similarity. I'm sorry. This has some similarity to the maxillomandibular advancement procedure. When you talk about this, this osteogenic, the Wilcodontics, how old must the person be, or how old can they be?
Well, there wouldn't be any reason to do it on an extremely young person because they're already like that. But once somebody gets into their teens, or the one that convinced me was Tom did his mother, and she was 79 years old.
Wow.
And he did this procedure, and she recovered very well. What I think is interesting about all this is it becomes so natural. One of the problems, my mother is in a nursing, she actually moved out of her nursing home and into assisted living, which I was real happy about. Mm-hmm. But as I was walking through the nursing home, everybody's laying there with their bed flat. Nobody has CPAP. Nobody has an oral appliance. Nobody has anything. Right. They're just struggling with whatever airway they have. When they're your and my age, they have a way of taking care of themselves with CPAP or an oral appliance, or their hands are not crippled and all these kinds of things. And so the idea that how do we maintain somebody throughout life is really an important point. And the interesting thing about this is if you have the orthodontics done like this, it's actually good throughout life. You have it there later, right, and you don't have to rely on another mode, because people don't only have a small airway at night, they have it during the day as well. And I talked to you a little bit about that. And I think the reason I went down this path was really the insomnias, mm-hmm, because I think people dose themselves during the day, and you know so much about that, but it's just my idea that I could change the amount of fight-flight response during the day would be wonderful. Right. The other thing, and then I'll stop on this, but the cost is much less doing this orthodontic procedure than it is doing two-jaw surgery. And it's and the trouble with it is, it's in most cases, I got to be careful here because I saw how Stanford does I just had at the course here in Columbus that we give, I just had Stanley Liu from Stanford come and show how they do their mandibular advancement and maxilla. It was
Casey Lee?
beautiful. No, it wasn't Casey Lee. It was Stanley Liu. He's Casey Lee is one of the other people.
Okay.
But I think Stanley is one of the younger people there.
Okay.
And I could get him to come. And so he showed these slides, and I never saw anything so beautiful as his surgeries. I mean, they were remarkable. I don't see that kind of two-jaw surgery done very, very often to that level of competence. And and so you get a lot of morbidity sometimes with not a lot of outcome. Mm-hmm. And the thing that I had some disappointments. And so with the orthodontics, you nothing lost, nothing ventured really. Mm-hmm. They're going to end up with better looking teeth. And then if you want to do a two-jaw surgery, they're all set up to doing the two-jaw surgery. The occlusion is the way it should be. So
it sounds
actually it could be a two-step procedure.
Yeah, it sounds like a randomized, controlled study, or just a comparative study. Looking at the difference between the osteogenic approach and the MMA would be very interesting because, as you said, one is more expensive, one involves more morbidity, but then again, the most important thing is what is the outcome?
Right. But a lot of the surgeries are not done with orthodontics first. So they try to advance the mandible and it's very narrow, or the maxilla is very narrow. And they wouldn't have to advance it as far as if you did the orthodontics first and opened that up that way. The reason I bought this fancy CBCT, I'm working on what I call the oral cavity volume calculation. Mm-hmm. And I calculate the oral cavity volume in the patient, and then I calculate the oral cavity volume with the oral appliance in with a known success rate. And then what I do is I see if I calculate the difference between where they started and where they are with the oral appliance, the oral cavity volume. And then I see if that's within the ranges of doing a osteogenic orthodontic procedure to see how close I can get to mimicking those results. And that may give us an indication of whether what the outcome is going to be from the orthodontics is what I'm hoping to be able to show.
How far do you think the osteogenic orthodontics field can go? Do you think it's something that can be very competitive?
Oh my God. This is hard to believe, Barry. I mean, there's a group in South America that I've seen work, and I don't know why the South Americans seem to be more aggressive than us. Maybe because they don't get sued as much or something. I don't know what it is. But they did braces, and you can move the teeth so quickly. It's amazing. Right. And they were actually putting brackets on the outside and on the inside so they could really push and pull at the same time. And I think as we learn how to do the orthodontic mechanics better, mm-hmm. we'll get better and better outcomes from something like PAOO. If you just do traditional orthodontic mechanics, you're probably not going to get much of a result. But if you really are going for expansion along with cosmetic appeal, you can get a lot more. And I've got a good friend in Chicago. His name's Brian Vence. Brian is a superior cosmetic dentist. And he and I have been working together on this for a long time. And what we've come to the conclusion is if you get the cosmetics ideal and perfect, the airway's better. Mm-hmm. It seems like cosmetics and airway go along. They run parallel with each other. In other words, if you get a good airway, you generally have great cosmetics. So it's not you don't make people look abnormal either.
That's a very interesting marketing 2-for-1 because it is so interesting how a lot of people are very obsessed with their teeth. And if you gave them this opportunity where you can say, well, not only can we work on your teeth, but we have a chance to affect your sleep breathing disorder. I would see that as being a very competitive field because obviously, as we've spoken, any procedure that has a long-term effect as opposed to having to long-term use CPAP or a dental device, lots of people would like that if they felt they could tolerate the procedure. I mean, MMA, unfortunately, I have to tell you that a lot of MMA I see are people who a few years later come back and we retest them and they need PAP therapy again. So it didn't really hold, which raises the question of, well, what kind of MMA, were they getting? If you
That's exactly right.
feel the orthodontic procedure has potentially more mileage, I would think that many people will gravitate towards that because people are always interested in something to cosmetically improve their teeth.
Well, that's it. It's not only the cosmetics, you get health. And I don't know how much health right now because I don't have it predictable, but you're going to be healthier when you're done than you were when we started. And people do, I mean, to me, that's more important than the cosmetics. I've had an overlap front tooth all my life, and that doesn't bother me much. I mean, I fix it all the time for people. They want these perfect smiles. And so somebody told me they want to do 2 veneers on me, I'd say, get lost. If they told me they could make me healthy, I'd say I'd get in the chair. I mean, that's just me. But I find it incredibly interesting. And the other thing that is different with the MMA versus the osteogenic orthodontics is the fact that you're not damaging muscle attachments in the myelohyoid area,
Right.
and that's a big deal. And so whenever you do a surgical procedure, you're going to lose muscle attachment,
right.
And then is the hyoid going to be as supported as it was before?
Right.
And that's what impressed me about the Stanford procedure, because I really thought that they controlled those things very, very well. And
that's what you mentioned there about health makes me want to revisit with you a little bit more this thing about success. For example, one of the most reliable outcome measures we have been using for about 20 years now are the trips to the bathroom at night. Because
that's a good one.
Sleep apnea patients, a lot of people still don't know this. They keep thinking, oh, well, you have sleep apnea, so it wakes you up. And then when you wake up, you think you need to go to the bathroom. So that's why you go to the bathroom. And, I have a video. It's called nocturiacures.com. It's just 5 minutes long. But it shows that the real reason is you have this extra fluid going into the right atrium. The right atrium distends in some fashion and thinks there's a false fluid overload. And so it releases the diuretic, atrial natriuretic peptide. And so you produce more urine during the night because the kidneys are overstimulated. So I remember when I first was given a dental device, first by Tom Mead and then by Dan Clifford, and this would be back like 1998 to 2002, I was amazed. I put a dental device in, and that very first night, I slept all through the night, no nocturia. And when I used my dental devices for several years, I had no nocturia up until the last year when it was no longer working as well for whatever reasons, and the nocturia came back. The reason for this lengthy preamble is just I want to get your take on what you're seeing in terms of different kinds of symptoms. In other words, are you hearing about the nocturia changes in your patients? Are you coming across any of the glaucoma patients who are talking about how their doctors are telling them that when they went on PAP therapy, they said the glaucoma got better? You mentioned the diabetes, but I'm curious to know any kinds of symptoms, outcomes, whatever, that help you further either quantitate the success or just in terms of a qualitative change for the patient. Because I do think that people, and dentists in particular who are going to go into this field, they really have to know these things so that they can motivate their patients and say, well, how would you like to how would you not like to wake up at night and not go to the bathroom? Does that sound like something you would like to be an outcome? I'm just curious what other outcomes you look at.
They're really funny. People always telling you different things. The one that I like, the Nocturia is a really good one. I mean, we keep track of that too, and we watch that go down. And as that drops, then we feel like we have better success. You can also get into the erectile dysfunction thing, and that David Gazal at the University of Chicago did a study with the mice where you increase the intermittent hypoxias, and like you said, the little guys went down, and you corrected that and gave them normal air, and it went back, and
right.
They could run it up and down depending on whether the number of intermittent hypoxias. Mm-hmm. So we've had pretty good success with that. I mean, that'll tell me about it. Maybe 10 people. Yeah. We've noticed pretty good weight loss, which I've been amazed at, and it seems to be consistent. It goes back, what I think, is to the fight-flight system. Mm-hmm. The idea, and I may be taking this too far, so just take it with a grain of salt or whatever, but we are really ancient peoples on this earth. We're still 20,000. Our autonomic nervous system is thousands and thousands, maybe even 1 million years old. Mm-hmm. And it was always there to protect us.
Right.
And when you were under stress 20,000 years ago, and the stress normally was they didn't have food. That's always the problem with ancient humans, because as soon as they got more food, they had more kids. As soon as they got more kids, they didn't have food. It was back. And so the right thing would be is if you're under stress, which may mean that you didn't have food, the right thing would be pull more calories out of food. And the other thing is you're never sated. So the right thing to do is to gorge yourself if food is there. And it seems like we control those basic symptoms better once we get the heart rate and the fight-flight response more under control than normal. We hear that. One of the things that I have people breathe through these little straws for demonstration, these little 4 straws. They're the kind like you get in a bar to stir a scotch with or something. And if you breathe through 4 of them, normally you can breathe through things pretty easily. And people can breathe in and out, no trouble. Take one away, and all of a sudden, you can start to feel the epinephrine released in the body. Take another one away, and you definitely can feel the euphoria of it. But one of the decrease in airflow stimulates a lot of things, and I think I can demo it pretty easily in front of a group that way, and I've been doing that for years. But I had a psychologist in about 9 months ago in the office, and I showed her this. He says, well, that's interesting. And you know what they use those little 4 straws for? To create a panic attack.
Wow.
And I never knew that. And so the idea that you
either by blowing off too much CO2 or trying to build up CO2?
The idea of trying to breathe the air through these straws and pulling hard, what I assumed it was release of epinephrine. I don't know whether it might have been the CO2 or not. I hadn't considered that.
Well, do the patients breathe in and out through the straw?
Yes, they do, because I haven't pinched their nose.
So they probably, there's an older theory by Donald Klein about how CO2 changes are associated with what's called false suffocation alarm. And so just little changes in CO2 for sensitive people seem to trigger it. So it could be what you said about the epinephrine, but it could also be that as they try to breathe out, they really can't exhale that well because they can probably pull in better than they can breathe out, is my guess. And so they may have a little bit of CO2 buildup, and that may be part of how they could produce a panic attack.
That's why it's so great to be around somebody that knows. I always have these ideas floating around my head. I love to talk to you about them.
That's just a theory.
But I thought it was interesting that these people, I had one lady who was seeing a psychiatrist 3 times a week, and she'd been seeing him for about 8 years.
Mm-hmm.
And now she's not seeing the psychiatrist anymore. And I thought that was interesting. You know, I never really bring it up. I go back to Pete. You know, the older, the dentist that I talked about earlier. He's off all of these blood pressure medications. I didn't say anything about that, you know, to the physician, or I didn't say anything to Pete to do, you know, but his physician took him off of them because he didn't feel they were required anymore.
Because he started fainting. He started fainting from having too high blood pressure. I just saw a patient.
That's exactly right.
Earlier this week. That was the other one I was going to ask you about. How often do you see things like at the opposite end of spectrums? Like, how often do you see blood pressure lowering? How often do you see something like depression getting better?
We see both of those things, Barry. I need to, you know, the reason why I was so impressed by all your work is that you've tracked things so well. And I feel like I came into medicine through the back door. You know, I kind of snuck in here, and I like what I do. But I was never trained to do research like with what you have done and create. I was so fascinated with your insomnia research. Mm-hmm. And, you know, those things we need to track, but I haven't tracked them. They appear to be better, but we hear good things all the time, but you know, if that's true or not true, how that is.
Well, I think we're on the same page. And one of the things that would be just amazing to track, and I don't know that anybody has done this yet. I've been pushing for it in several different opportunities, but nothing I've seen yet. Military personnel, even combat personnel, it would be so interesting and probably incredibly valuable to fit many soldiers, many service members with an oral appliance. Because think of the efficiency and the practicality of being able to use that in the field compared to PAP therapy. And of course, that even gets into the whole theory, you know, in our research, which is, what if you actually treated somebody's sleep problems before they were exposed to combat? And what if by doing that, you actually lessened their chances of getting PTSD? So I'm hopeful that, you know, somebody's going to come along to the Metz Center and the Metz group and say to them, you know, we want you doing something, you know, with our military personnel, because that's been needed for a long time. But I think the military, you know, they've slowly but inexorably begun to become very interested in PAP therapy, which is good. But by the same token, they should be very interested in dental devices, given the expediency, the efficiency, the cost, everything. It'd be an incredible opportunity that so many people would take advantage of.
Oh, I agree with you, Barry. And you know how much of the PTSD is actually the release of epinephrine or the inability to sleep, or just maybe not sleep apnea, but kind of a pre-apneic event, upper airway, you know, could be a major instigator of those problems. Mm. And that would be, and it's so easy to do if you had the population. That would be interesting.
Right. Absolutely. I want to come back now to some areas we started off in the beginning regarding, you know, doctor and dentist relationships, and tie that in to some extent to, you know, where you think things are going in the future, and especially about, you know, you've mentioned some things about, you know, how we spread the word, but in particular, I want to hear how you feel doctors and dentists have to connect, and what should be happening, you know, from both sides of the aisle, so to speak, so that people can feel both comfortable, confident, and motivated to do this? Because we both agree that's an essential a change or objective that has to happen for us to make more progress.
Well, I vacillate on this one, as to what I think. Oral appliance therapy is really quite hard. It's not an easy technique to do well. Anybody can shove an appliance in there and say you got an appliance, but to do it really, really well and get the outcomes that we were able to get, it takes some real talent to be able to do that. And then you take it one step further, and the number of people who need oral devices versus the number who could possibly even get devices. If, say, the military wanted 1 million of these appliances made, I don't know how they would get them. I have an idea how to get them made. But theoretically, if you approach dentistry, there'd be no idea. The person I know that makes the most appliances in the United States is one dentist. It's a good friend of mine, and he makes 50 to 60 appliances a month, which is really very low. But that's twice what I make. I'm making about 30 in a month, I imagine. And but I was really surprised in China. China has a way of slapping you around a little bit, and I went into this small hospital in Pudong, and I've spent quite a bit of time there. And Dr. Liu, the head of the hospital, said, Metz, we like your appliance. We really like these. You made all of our physicians feel better, and we want to be able to make those. We want to make 1,000 a month. How do we do that? And I, of course, I about fell off my chair, because if you do the titration process that I'm talking about, I would need 100 Chinese dentists to do 1,000 appliances a month, which isn't practical. You can't do it. There's less dentists in China than there are in the United States.
Wow. So
this has put me for the last 4 years on a real path as to how this is all going to work out. And David Gazal, I brought him up before. I met him in China. It's been a couple of years ago, and he told me, he says, Metz, you've got a great idea here, but you have a boutique appliance. It's really never going to impact much of anything. And I think that's about what we can say about oral appliances right now. They really can't impact much of anything because not enough of them can be done predictably. And so anyway, he said, you got to figure out a way to do it. And he told me about a group in Syria that was making artificial limbs for people. He says, well, how much do you think an artificial limb would cost? I said, I don't have any idea. $7. He says, that's what we need for the developing world. And he's absolutely 1,000% right. So it's put me on this path to figure out how in the world to do a bunch of these appliances for less money, because it's hard to work within Medicare for these appliances, and everybody wants them within Medicare. And Medicare and reimbursement's too low, at least in Ohio it is. So I ran onto this idea of how to adjust the appliance. And for 80% of the people, I think there's a predictable way of adjusting the appliance, and have maybe 2 or 3 appointments, and 3 appointments for the patient, total of about 2 hours, and they're pretty much done, and they pretty much work, at least to the less than 10 level of success. And that it sort of takes the guesswork out of it. It makes it so the patient, the dentist doesn't need to know hardly anything to make these things work. And I think that's almost where we have to go, because nobody wants to put the kind of time into it that I have. It's just too much. And you have to charge too much. Like we charge way more than Medicare fees for one of our appliances. Right. But what it also means is if we do this and we find a predictable way to make these appliances, and we use intraoral scanners, which just, you go on the inside and it creates a 3D model of the teeth.
Mm-hmm.
It means that a lot of the true dentistry is taken out of it. And what my worry is, to be honest, is I would, it's why I got here to begin with. Who's going to end up doing these in the future? Dentists want to make a certain level of money in their office. And this takes time to do it the way we've done it in the past. And so some become interested, but a lot choose not to do it. And they don't want to deal with TMD. They don't want to deal with problems. They don't want to deal with anything. Mm-hmm. And they just want to, kick out the kind of the easy stuff. I hate to say it, but that's where it seems to be. Mm-hmm. And I think there's a possibility this may move into medicine rather than into dentistry, and because I think it's too important of a modality, especially for heart and disease processes that we may see the PTSD, as you just talked about. These things need to be made in mass quantities, not just as a boutique at Dr. Ghazal talked about. So mm-hmm. We're actually planning a clinic that would allow 3 dentists to maybe do 1,000 appliances a month. And now all of a sudden you can make an impact. And that's what we need, because a lot of people need this care. And it shouldn't just be for the wealthy or the well-insured. It should be for everybody.
Right, but from a free market point of view, I mean, as I've been mentioning in some of my blog posts, and I believe talked about a year or two ago, the whole healthcare system, we're talking today, when the House just passed, the repeal on the first phase of repeal for Obamacare. But what's more important is there's so many people out there who understand that the free market principles of healthcare really have to be implemented. Everybody looks at what happened with LASIK eye surgery, and everybody applauds it, and people are pleased by it. And you say to them, you're aware that there's no insurance for LASIK eye surgery, right? And some of them go, oh yeah, that's right. So I disagree a little bit with what you're saying, only in that there's so many dentists in America. There's so much opportunity for dentists in America to be able to help, even if they're helping, 50 people a year. That's a lot of people, and hopefully they're using good, devices. Hopefully they're getting good training and getting experience where they're learning to fit the appliances properly. But I feel very strongly that dentists need to get into this market from their own perspective. I mean, I look around at all the stuff that changes. I'm sorry. I look around all the stuff that goes on in sleep medicine. I mean, sleep medicine itself is having its own problems, and they don't seem to be able to solve them. They have less doctors. Sleep centers are closing. There's real concerns about sleep medicine, and yet now you have something called, get this, the American Academy of Cardiovascular Sleep Medicine. Well, that fits into the model that I was trying to push for several years in my own hometown of going up to cardiology groups and saying, hey, how would you like to have a sleep lab in your heart hospital? And nobody has done it yet in New Mexico, but I think that's what's going to happen. People are going to ask for these things to be expanded. So the dentists absolutely have an opportunity to become primary sleep providers. They have their own academy. Yes, they have to overlap with the sleep testing. It has to be, currently and appropriately, the home sleep testing model or the PSG testing model. Those all have to be read by a board-certified sleep doctor. But I absolutely want to encourage dentists to feel motivated to get into this field, because there's just not any way that you're going to have all these people either use the PAP device, be able to adapt, or would even consider it. And a dentist is, I think, the perfect marketer, so to speak, to get that person interested in teeth, in airway, and snoring. I mean, there's so many points that they could bring up and it could become a part of their regular practice. But I'm not a dentist.
Well, you're exactly right, Barry, and I agree with you. And it is a part of my regular practice. My practice has exploded since I've been doing this. I went through the 2008 kind of downturn we had, and people weren't buying full mouth reconstructions. I mean, because nobody cared anymore enough to part with their money to have one done.
Right.
Well, all of a sudden, I'm doing as many of these as I can do, simply because they want it for a health reason rather than for a just a cosmetic reason. Or if they do get a health outcome, they want it. So it really creates a very remarkable dental practice if you go this route. But what I was at, I think I was in Denver, and we were at a sleep meeting there, and one of the dental manufacturing companies, one of the large ones for oral appliances, put out their goals for next year. They wanted to produce 70,000 appliances for the next year. And if they did that, that means probably 20 of the 70,000 are replacements of ones that are already out there, and only 50,000 are new. And I thought, wow, 50,000 of appliances for the whole country, that would fix probably a mile and a half of radius from this convention center, and I think it is just so tiny compared to what we need to have. And it's an interesting thing. I have dentists that they come to the courses, and the ones that'll come and learn are doing really well. I mean, we've trained a lot of dentists that are really doing quite well in their practices, and they're doing 15, 20, 25 appliances a month and doing a really good job at it. But, then you see the advertisements for the other stuff too. And I saw an oral appliance at one of our organizational meetings. I swear it was a hockey puck that had just been cut down a little bit. It was the size. It was the biggest thing I've ever seen in my life. And this was supposed to go in a person's mouth. And, women have always been shown to be a higher failure rate than men with oral appliances. It's because I think they got a smaller mouth. You can't fill it up with, proportionally, you fill it up and they can't handle it. So I don't know what the outcome is, Barry. I hope it stays within dentistry, because this has given me a path and a calling almost of life that I really value, and I think it's extremely important, and nobody can keep me away from doing this. I mean, this is like, I like doing my other life, but this life is better, and the patients are so happy. They come in and they're just nice people. I mean, you turn a grump into a nice person.
Right.
It's kind of
decrease the irritability.
It's kind of cool.
Right.
Yeah, and then they walk in and
go ahead.
They're always clearing their throat. They're, all the GERD stuff.
Right.
And then you just listen to them. You hear, hey, yeah. They have the old cigarette cough. I can't quite do it right now. And that's a problem. The breath should always be silent. When they have that kind of raspiness going on, they've got an airway issue.
Right.
And bad things happen when they don't fix it. And especially in men 40 to 50 years old. We all know that statistic. It's not good.
Right. So, this video will on the probably on the two websites, probably on the Sleep Care and also the HST America, which is the newer company they've worked out to help dentists get started in this field, where they have this relationship where HST America can arrange for the sleep study, and then they can get it read. They can get that whole thing worked out so the dentist can go forward. talk a little bit about either in your early years or just currently your advice to dentists who are looking to get into this field and maybe have some of these worries about having to interact with doctors, and they're not really sure either how to go about it, whether it's building their own practice. And any thoughts at all about that, helping them, go forward?
The best, I kind of stumbled through it, and I got there. But what I think you need is a mentor. You need someone that's already gone in front of you. And you may find someone in your own community. And if you don't have anybody, pretty much what we've done, and I don't mean to promote our courses, but what we've done with our courses is foster the interaction between physicians and dentists so they can become accustomed to talking to physicians and asking them questions and knowing what physicians think and just kind of know that they do know a little bit. The biggest thing is I think is learning the vocabulary and actually being comfortable with the vocabulary, because I'll walk into a group and say, well, we've had several sleep lectures, but we're not quite getting it. So I'll go down and I say, okay, I hate to say it. I used to start off with what's an RDI, and now I ask what's an apnea, and I'll get maybe one hand in the room, and somehow the bigger picture is getting lost. And I think if you show the person the path, they'll figure out what apnea-hypopnea is. I mean, they'll want to learn it enough because they'll start reading and they'll understand. But I think you have to have someone take you by the hand a little bit, and that's really what we've been doing. We have an email list, and people can ask questions on it all the time. And it's sort of like a blog, but it's not really a blog. It's just it's within the Google groups. And we answer questions all the time, and one person will answer, or I'll answer, or somehow they'll get an answer to their question. But I think the other thing that's helped me, and the biggest, how would I say it, educational boost I've ever had in my life was joining the American Thoracic Society. I've been going for about 6 years. And I sat in there the first time, and I realized I could not open my mouth because I didn't know anything that they would want to listen to because I had no data. Dentistry runs on no data. It's mostly, I say, eminence-based literature instead of evidence-based literature, and so people follow people as a dogma or as a disciple or something along that line. Right. And you go into a medical arena, and that's not the case, not nearly to the level it is in dentistry. And there's not been a whole lot of money spent in dental research on sleep. I mean, we've done all of ours on our own, and our study cost almost $200,000 to do, and there's nobody paying for it but me. And that's, but it was important to me to get that done. But I've learned through the ATS that they stand up and they state a point and then prove the point, and this is how we proved it. And I almost had to learn that from a physician to know how to communicate, and that's why I don't really go to many dental meetings anymore. My major one is the ATS because I lecture at a lot of dental meetings, but, I see things, but nothing ever tweaks my interest a whole lot. What really does, though, is a group of physicians talking about the whole idea of different types of PAP therapy. Like what's an ASV, what's an auto PAP, what's a BiPAP, what's a traditional PAP. Yeah. And I think we need to know all those things.
Absolutely.
And so I've really gained a lot from the ATS, and what's been interesting is they've reached their hand out to dentistry, by even allowing me to form a dental interest group as an attached to the sleep respiratory neurobiology section.
That's great.
And then they asked me to be on their executive board. So, I mean, they want, like you're saying, they know the oral appliance is a good thing and they want it there, but how do you get a dental group to come? And I have about 100 dentists coming to the ATS now.
That's outstanding. That's the way to spread the word.
That's the best way I know how to do. I don't know. I think you got to be around these people and realize they won't bite your head off.
So I know that you mentioned courses. So yeah, please advertise your own. And I know that HST America also has courses, and that's one of the first things that they realized was important, was helping dentists learn about all of this so that they're going to be confident and comfortable going forward. If they are not given some level of education, then they're not going to just jump into it. And it reminds me locally that when we refer our patients for treatment, they often say, well, I'll just go to my dentist. And we say, well, no, you actually want to go to somebody who's fit 50 or 100 people and has already made this part of their career. So I think that is very important, that people can't look at it as something to dabble in. They have to be committed. And I think if they take courses, perhaps join the Dental Society and get an education, they will realize how much there is there to learn and how much there is to offer the patients, especially in all these health outcomes we've been talking about.
That's exactly right, Barry. I think there's actually two levels. You need to learn AHI. You need to know what an appliance looks like. You need to kind of get in the dental groove. And then it seems like you graduate. And not that you leave that behind. I still go to the meetings, but I'm not as into that. We're all set there, and I won't miss a talk is at the ATS. And all of a sudden, that's been the next bump in in my education. I have a good friend, Frank Seaman, and I was going to the sleep respiratory neurobiology section, and he said, Jim, I don't think I want to go to that. I'm going to go into this pulmonology meeting. I said, Frank, what the devil do you know about pulmonology? He says, I don't know. It's about the lungs, and I want to see what it is. He had read deeper than that. I just hadn't read it. But what they were talking about was mucin. And we got to talking, and they spent the whole afternoon on mucin, the covering of the airway. And what was interesting and what he found is that mucin comes in several different types, the different mucks, as they call them. And some are thick and some are thin. And they all know that a thin mucin is better than a thick mucin. And so, but they did not know how to change that from a thin to a thick, or a thick to a thin, rather. And what Frank said was pretty obvious. You turn them into nasal breathers. But a physician did not know how to turn a patient into a nasal breather, but a dentist does. And that was where there was real synergism, I feel. And the one that's come up with me recently is when people who do get a turbinate reduction or get rid of the inflammation, they say, well, it'll be back in 3 years. It'll be reinflamed and you'll have to have it done again. Mm-hmm. But what I think is not if you control the GERD and the blockage at the back of the throat with an oral appliance, that might not recur. And we might change mucin from thick to thin, and that the thin doesn't hold bacteria as well, and it doesn't stick the airway together as well either. And so you actually breathe better just by having different mucin. And I felt that was really interesting. I would have never thought of that or even considered it until Frank went into this other meeting. And that's the possibility.
We've got about 10 minutes left, and that segues nicely into my last question for you is I'd love to hear about some of your, I know you don't think of yourself necessarily as a trained researcher, but I know you have a very creative mind like a researcher, and I'd be curious to know what are some of the research studies, investigations, and so forth that you want to see happening, whether it's with your own group or somebody else. And if you have your own particular research projects you're hoping to go forward with, if you want to talk about any of that, I think that would be very interesting for people to hear, since you have been thinking about this for so long, and I know you have a lot of ideas, some of which you may have to keep secret. I understand.
The number one is, what's a good oral appliance? How do you predictably get an AHI to less than 5? How do you do that? That was my first research, and I feel like we're pretty good there. I feel like we've gotten kicked around a lot. It's taken us almost 3 years to do it, but we're doing pretty well with that. The one that there's this thing with the tori. I want to publish that. I think that'll publish. The thing about the PAOO is really unique, and be able to follow that as a long-term study would really be remarkable. What if we could actually do an oral appliance, figure the oral cavity volume, be able to know that we were within ranges for a technique like PAOO, do it, and the patient resolved from their sleep apnea? I mean, that hasn't happened. But I know sooner or later they're going to be back into it again, because sleep apnea must be managed. Nobody cures it. Throughout life you get the peak crit changes, the critical closing pressure of the airway, and it changes with the age. It gets more and more collapsible. Mm-hmm. One of the ones that bothers me is dentists become, I think we need to prove what we do. And one of the things that's really kind of a thorn in my side right now is there's a lot of frenectomies being done, lingual frenems. Mm-hmm. And we have, Mickey Harrison works with me along with Jim Blank, but Mickey, 3 days a week, 8 hours a day, all he does is read the literature. So that's where all of our data comes from, is from Mickey. He doesn't see patients, and he's been doing that for over 4 years for me. And so he's really a research assistant to me, or a research person, but it's allowed us to know where we're going and how we might get there through Mickey's brain. And we spent 3 months trying to search down every bit of literature on whether it was correct to take away a lingual frenum or not. And the fact of the matter is there's no literature to prove much of anything there. They'll say it's in the Brazilian literature. We translated the Brazilian literature. It's not there. They'll say they do it, but there's no data behind why they do it. Mm-hmm. We found in the Japanese literature that it causes the hyoid bone in some cases to descend if you take away the lingual, which means that it may make the apnea actually worse. The lingual frenum may be a protective mechanism for that particular person. It may not be. Who knows? Everybody is such an individual. We know that, the failure to latch and all that with the, for breastfeeding is what it's done for, but it's done so overwhelmingly to everybody now. I wonder about that. And then if it hasn't gone away by age 6 or 7, then the anterior maxilla doesn't develop properly because the tongue doesn't push up against the roof of the mouth like we talked about earlier. Mm-hmm. But the fact of the matter is we just go in and do a surgical procedure and change someone permanently without data just really bothers me. And I keep asking people, they do these all the time. And I said, well, keep the numbers on it. Keep the data on it. Mm-hmm. And nobody keeps data on it. And I wish dentists would do that. My favorite one that I'm really looking to do is a funny one. I'm convinced that our personalities are centered around our airway. I think the people with a more deficient airway have a different personality than people who have a more normal airway. And I've got all kinds of ideas about that. I don't want to let those go, but I think, we think we are who we are because we're this person and we trained ourselves to be this way. I think we're much more victims of habit than we had ever imagined. Just like You see somebody with a forward head posture, that's a problem. You see somebody staying there chewing gum incessantly. I know that's a problem. I was just at I was actually at a temple in the bat mitzvah, and everybody in the group, there were about 10% of the people were just chewing gum like crazy. And I asked my friend who's a member, I said, is there any way we could do a pulse oximetry on these people that are chewing gum like crazy? I would be willing to bet they have a terrible airway. And I think just some crazy stuff like that would be fun to do. It's like it gets into alcoholism too. We need to test this because people who can't sleep, they're going to make themselves sleep. If you don't give them Ambien, they'll find Jack Daniels or something.
Right.
Right. And there's so much of what we do as a personality and the disease processes we have going on could be so interrelated. I don't know whether you know Nick Netzer or not. He's the Sleep and Breathing. He's the editor.
Right.
And I was in Berlin, and I think it was 2007 or 2008, he was the lead-off speaker. And he stood up and said, name any non-cancerous systemic disease, and all connected to sleep apnea. And it just blew me away. I'd never heard a statement like that come out of anybody's mouth. And it just struck me how prevalent this problem is in so many people and how much damage it's causing people. And I guess the last thing is dentists try to be nice. They'll tell you, hey, you got a cavity there, or that front tooth doesn't look quite right, but we can watch it and go for the next time. And I was sitting in an airplane flying somewhere, and the guy said, oh, you work with sleep apnea. And I said, yeah, because I had my screen up and everything. I'm always working on this. And so he says, well, I got it. And it was like he had won first prize at the county fair, like I got sleep apnea. And so I said, so you wear CPAP? He said, oh, no, I don't like that, GD thing. I said, oh, that's too bad. That's a good way to treat it. And he said, so you're a dentist. You probably make one of those expensive oral appliances that I'm not going to spend my good money on that either. I says, you guys are just, you guys are just money grubbers. You just want money all the time. I said, oh, and I knew I wasn't getting very far. So I let him go to sleep, and he goes, and he leans back in the chair, and he wakes up, one of those kinds of things. And he says, was I asleep? And I said, well, he said, you stopped breathing and you woke up. And I said, so what do you do for a living? And he said, well, it's funny. I retired at 63. And I'm really happy because, you work all your life to have some time with the kids and retire and everything. And I take care of my 3 grandsons. They live really close to us, and I take them to the ballpark, and we play t-ball, and we go, they were the Orioles. And he says, we go watch the Orioles play baseball. And I said, oh, that's really interesting. So you really like taking your kids to the ball game, huh? And being around and be healthy and being able to walk up the steps and all those things. And he said, oh, man, that's what I've lived for. I said, then why in the hell don't you get your sleep apnea fixed? Because all the things that he wants were going to be prevented by him not treating this because he was a severe sleep apneic.
He couldn't.
And what's interesting is
he couldn't connect the dots. And that
connect the dots.
And that brings me to the last study idea. I want to just run it by you quickly. But wouldn't it be amazing? I'm sorry.
What he did is he went to see my friend in Baltimore and got an oral appliance.
Very great.
Good.
That's good to hear. That's very good to hear. We need is a very thorough study comparing OAT to CPAP based on the idea of cost effectiveness. Because, in my world, as I've mentioned, we don't use CPAP. We use auto bilevel and ASV. So we think we get a much better response. But nonetheless, most sleep centers still use CPAP, and a lot of people can't use CPAP. And so if you were to do the study that shows, and I think there's actually been a study very recently, just in the last couple of years, that looked at OAT in comparison, and it showed that, because so many more people will use the OAT, that cost effectiveness-wise, you're actually getting a better response compared to all those people who drop out because they can't use the CPAP. I think more research is needed like that because we are going to be seeing more people go towards dental devices in the future, I think.
Oh, I believe that too, Barry. But honestly, we in dentistry need to get our act together and need to learn what we're doing. And it's just not putting in plastic and say, see you later, like it is for everything else that we do. You have to follow up, and make sure that these patients are receiving the level of health care that you would want for yourself or your family. And that's what's why there's some pushback now, from medicine that dentists should not be using screening devices. And I don't know how, I couldn't have ever learned anything without them. And I wouldn't know where my oral appliance was or how good it was.
Right.
Now, I thoroughly believe that they should have a clearing study with either an HST or a PSG and not rely on the pulse oximeter. But while I'm adjusting the appliance, I need eyes. I need good eyes. And so many dentists want to run right out and buy a high-level HST to titrate appliances with. Well, it costs too much, and it's they're getting too much data. And sometimes they're not getting the right data, what they need. And that's the reason why I think scaling it down to pulse oximetry, well done, can give you all the data you ever need for all appliances. And so,
well, that's anyway, actually a great finishing point and a marketing point for our company, HST America, because they are not selling the devices. They are actually implementing a strategy to facilitate that entire process for the patient and with the dentist. And I would say that the reason the HST is more important than the oximetry as we get more advanced technology is that we can actually get devices that measure the upper airway resistance. And you can get that with the model that they're using at HST America. Jim, I believe we could keep talking for another 2 hours, but I've got a patient coming.
I love talking.
You've probably got something else to do, but it's been great. It's been terrific talking to you. I'm sure we're going to probably have a chance to talk some more. We've always got things to talk about. I really want to thank you for all your time, Dr. James Metz from Ohio, Columbus, Ohio, doing so much work in dentistry, sleep dentistry, restorative dentistry, and wish you all the best of luck in your future endeavors, and let's stay in touch.
Thank you. I really enjoyed it.
All right. Have a good evening.
You too.
Take care. Bye.
Bye.